the cornerstone defect in this problem is an amino acid substitution in the gene encoding for G6PD located in the XQ28 region on the tip of the long arm of X chromosome. So how we deal with it? We avoid precipitating factors. We transfuse blood in severe hemolysis just for support. Maintenance of good urine output during hemolytic episodes, likely with hydration. Folic acid, we mentioned that before, that the demands for folic acid increases with hemolysis. Exchange transfusion in newborn. So we're done with that. Another case, a 36 lady present with anemia syndrome, like the whole package. Shortness of breath, exertional dyspnea, headache, poor concentration, fatigue, and splenomegaly. She was mildly jaundiced. Hemoglobin is 8. Retic count was 10%. Platelet normal. LDH is high, more than 1,000. Bilirubin was elevated at 3. DAT negative, which indicates the absence of autoimmune process. So what do you think about that patient? If you just look at the blood film on the left side, you can see that the red blood cells look more circular than the expected oval shape of those red blood cells. If you look in the middle about the osmotic fragility test, when they change the osmolarity and observe and monitor the red blood cells destruction rate at one concentration do these red blood cells are destructed. You can tell that in hereditary spherocytosis, patients can have more significant hemolysis at a lower differential concentration. And if you look at the ultrasound, I mean, you don't need to be an expert in ultrasound, but this ultrasound is showing you a splenomegaly. This is what they want to tell you. So hereditary spherocytosis, it is there. It appears more in Northern European as opposed to the G6PD that was rarely seen in that kind of particular population. So prevalence likely 1 in 5,000. Clinical severity is highly variable as well, but uniform within a given family. So people know because they have at least an uncle or an aunt or maybe one of the first degree family members who have chronic hemolysis. You would expect that they would have the same clinical presentation. For example, if they require blood transfusion on a regular basis, or if the anemia is not so severe, if they have a recurrent gallbladder stones, or stuff like that. So typically the clinical severity is kind of similar among the people from the same family. Typically, it's an autosomal dominant. Homozygous form is very severe or sometimes fatal. In some rarely situations, it can be inherited through an recessive pattern. We don't typically offer splenectomy for those patients. As we mentioned before, in hereditary spherocytosis, the defect is in the membrane. So even if you remove the spleen, the defect in the red blood cells will not go away. And the ability for those blood cells to be destructed will be likely high, regardless of the removal of the spleen. So molecular pathology, partial deficiency of spectrin in the membrane, combined deficiency of spectrin or aneirin in the membrane, molecular defects, mutation of aneirin, that's the most common way to inherit hereditary spherocytosis, mutation of band 3 protein or mutation of protein 4.2. That's common in certain people. So this is the RBC membrane, and you can see the spectrum on the lower half of the left side of that uh, graph. So what's happened in the spleen in those patients, because those RBCs are quite defective, the spleen over work trying to get rid of those defected red blood cells, leading to having an enlargement in the spleen, and sometimes due to the chronic form of hemolysis, those patients can get another problems like the recurrent gallbladder stones and the acute calcular cholecystitis related problems. So another case, an 18-year-old male complains of acute pain in his back, dizziness, fatigue, and shortness of breath. So the anemia syndrome. Headache for the last 6 hours. So this indicates an acute drop in the hemoglobin level. He had similar attacks in the past. You can see in the middle, you can look at the smear and see the lacunar forms of RBCs, and we call that the sickle cells. You can look at the right side where you see the hand in which there's a deformity in the middle finger. You can look up and see the jaundice in the eye or the yellowish discoloration of the sclera. Looking to the left, you can see an ulcer in one of the extremities, which can be caused by the lack of blood flow in that extremity as a secondary to clot formation. So sickle cell disease inherited as an autosomal recessive
دكتور
pattern. نعم.
سوري على المقاطعة، بس سؤال الصورة اللي حاطينها قبل اللي هي هاي الاكس راي، ما يعني ما فهمت ايش علاقة الباك بين والصورة بموضوع السيكل سيل انيميا.
Very good question. Very good question. Excellent question. هلا بالsickle cell, the pathophysiology behind having all of these issue is the lack of blood supply in many organs. So behind bone, you can see some hypodensities related to veno-occlusive events leading to a lack of blood supply to not only to the bones but also to another areas in the body. This can be called as osseous finding, which, as I said, indicate lack of blood supply due to the micro to the veno-occlusive events. So a sluggish blood flow in the small venules due to the sickling that happens inside the blood vessels. So the hemolysis takes a place inside the blood vessels and cause those small blood vessels to be blocked. And in the bone, you can those hypodensities indicating necrosis because of the lack of the blood supply. Is that clear?
Yes.
Great. So again, the sickle cell disease, it is inherited as autosomal recessive. There is a point mutation in beta globin gene. Occurs in, so it's more prevalent in African American too. I mean, I don't like that terminology. How about we say it's more common in black people? Because you can see black people in Jordan and in Africa and in America and in Europe as well. So those Black Jordanian population, they are not Black American. They're not African American. And you can see that the prevalence of sickle cell disease is more common in people who have Negroid feature, to put things together. So on the left side, you can see the normal red blood cells. You can see the sickling occurring on the um, left side, the left blood smear. So what is the clinical features of this disease? As you can tell, chronic hemolytic anemia and its consequences of having gallbladder stone and the risk of calcular cholecystitis, risk of red cell aplasia. We had that term mentioned before when we talked about the chronic hemolytic anemia and the co-infection with parvovirus B19, where the risk of pure red cell aplasia is quite significant. It's not the common, but it's there. So a decreased vascular tone, as I said, no or not reduction in the blood supply, especially in the small venules, which can lead to many uh, necrotic events, pain, like pain crisis, recurrent infections, tubular necrosis in the kidneys, uh, necrosis in the bones, and stuff like that. So why they're having a higher susceptibility for infection? Likely due to the functional asplenia because of the multiple infarcts that hit the spleen on many occasions, which reduce the function of the spleen. So they might be having a hypo-functioning or a-functioning spleen. So these vascular events or the veno-occlusive crisis can affect anywhere from their brain, lung, ankle. They can cause erectile dysfunction of the penis. And you can see one of the most severe complications of that disease when you see end stage vascular lung disease. So just to understand the sickling in a simple way, imagine a disease that is causing a drop in the hemoglobin because of the chronic hemolysis, a disease that also can block the blood vessels as a result of producing these cells, the sickling cells, so the abnormal red blood cells, they clump together and close these venules, leading to inappropriate or less than optimal blood flow in those blood vessels, leading to a block in the small blood vessels with the consequent necrosis in the affected organs. So it's very simple. So as you can tell in someone who's not having a fully functioning spleen, uh, infections when encapsulated organisms are expected, like the pneumococcal, Haemophilus, stuff like that. And there's a common association between the osteomyelitis and the sickling as well, with the Staph aureus infection. So autosplenectomy occurs in sickle cell disease. We already know that. And as I said, you can expect any form of complication that is related to the lack of blood flow to a certain organ. So vaso-occlusive pain crisis, where the blood vessel, the blood does not reach to the periosteum of the bone, where then our bones cry for help, and that's why those patients present with severe, sometimes very severe forms of pain, hepatic crisis, splenic crisis, priapism, stroke, chronic lung disease with pulmonary hypertension. It's likely a late complication. Renal failure due to tubular necrosis, avascular necrosis of bone, as the X-ray photo that you've seen a few slides ago. So this is the avascular necrosis of the femur. You can see that the bone density is not good in the middle of that, in the middle part between the metaphyses and the joint. So what are the serious complication? Acute chest syndrome. People can die of this symptom, of this syndrome, where people typically present with acute form of shortness of breath, cough, fever, stuff mimicking pulmonary edema plus minus infection. So you don't really know what's going on. So you start your patient on oxygen supply, steroids, antibiotics, diuresis, hoping that your patient will improve. And if they're not improving, and you exclude the other causes, you might perform transfusion exchange. So you get some of this abnormal blood and you infuse your patient again with normal blood, just trying to dilute the effect of the sickling. Sphenic sequestration, massive hemolysis. So people can cope with a chronic form of hemolysis. For example, patients with sickle cell typically have a baseline kind of hemoglobin, like a stable hemoglobin level at 10, 11, 9. But in response to certain circumstances, like tissue hypoxia due to a surgery, an injury, an infection, they might have an acute form of hemolysis. And sometimes that hemolysis, that acute hemolysis, can be severe enough to cause fatal complications and sudden death. By the way, so cardiovascular accidents are very common with those patients. And I guess they are one of the most common causes of death for those patients, because you know that those patients, they do not live long enough because of these vascular events. So sickle cell anemia, painful events, management principles. Of course, you optimize the hydration status and electrolyte. You treat any underlying condition like an infection, hypoxia, stuff like that. You prescribe analgesia as required if it's not complicated. So what do we mean by complicated? If so, the uncomplicated pain crisis, the pain crisis in which patients respond to the previous three therapeutic approaches. So hydration, analgesia, and treatment of the underlying cause. If the patient is responding nicely to those three therapeutic agents, then the pain crisis that he or she has is not complicated. But if it's not responding and the patient is having a lot of pain, despite all of these, then we can transfuse patients with blood in case they're having anemia, or if their hemoglobin is satisfactory, we can perform transfusion exchange, where we get some abnormal blood out of the patient and infuse him with normal hemoglobin, just to dilute his blood and to reduce the risk of cerebrovascular event and improve the blood flow inside those small blood vessels in order to reduce the pain. So between those attacks, we prescribe hydroxyurea that increases the percentage of hemoglobin F. So those patients will likely have more normal hemoglobin, and this might reduce the risk of infection, hemolysis, and consequently the block in the blood vessels. I don't see any role of hydroxyurea in the acute events. Non-pharmacological approaches, if you want to sing to him. Prophylactic transfusion may have some benefit. It decreases the incidence of painful crises in pregnancy, for instance. So those painful crises come in clusters, like people continue to observe this pain for 5 to 7 days in average. About 4 out of 10 patients of the patients seen in the emergency because of that pain are admitted to the hospitals. Pain episodes account for the vast majority of admissions, of hospital admissions in patients of sickle cell anemia. And it comprise for the most cause of expenditure in those patients. So, as in any disease in which pain medications, especially narcotics, are prescribed on regular basis, people can suffer from or can either abuse or get addicted to those medications. There's a term called pseudo addiction in which people present with a relief seeking behavior, misidentified as addictive behavior. So, we just mentioned the acute chest syndrome, and we will talk about it in details because it's so important and it has a wide variety of differential diagnoses. So it is multifactorial, maybe because of an infarct, pulmonary fat embolism, maybe an infection. It is indistinguishable, so we don't really know if we're dealing with a pneumonia, and sometimes acute pulmonary edema because people present with pleuritic chest pain, fever, cough, tachypnea, and hypoxia. So how we know that we're likely dealing with an acute chest syndrome because of having a worsening anemia that indicates a progressively worsening hemolysis. You can see bilateral infiltrate on the chest X-ray. Most of pneumonias present with localized consolidation on the X-ray. So, what is the sequelae of the acute chest syndrome? Provided that the patient received the appropriate treatment, 90% recover, 3% go into permanent disability with permanent problems in their respiratory system. But the most important number is 6 out of 100 die of that complication. So if you have a sickle cell disease and you present with an acute chest syndrome comprising fever, shortness of breath, cough, pleuritic chest pain, every time you present with this symptom, there's a 6% chance that you will die from it, despite the optimal treatment. So how we prevent it? Typically, we offer incentive spirometry to reduce the risk of collapse, treat the possible underlying infection, bronchodilators, oxygen, blood transfusion. So there is a known concept in the sickle cell, a well-studied one, in which prophylactic blood transfusion were shown to be is shown to be effective in certain circumstances in producing either in leading to less complications or sometimes improving survival. So the first indication is stroke, and the expected outcome of blood transfusion is improving the recovery and reducing the recurrence by 90%. In acute chest syndrome, blood transfusion and sometimes exchange transfusion improve or leads to a rapid improvement in the symptoms and signs of happening in those patients. In aplastic crisis, definitely it's life-saving. Preoperative therapy, we do this all the time. It decreases the post-operative complications. We target our hemoglobin at 10. We target the sickling below 40. Symptomatic anemia leads to clinical improvement, and so on. I just want to mention that because in patients who have who get blood transfusion on a regular basis, they are at higher risk of having iron overload. and those patients can suffer from a wide variety of problems leading to, as a result, to iron deposition in their tissue, and that's why we sometimes use the iron chelating agent. Typically, people get a lot of iron stored or deposited in their tissue after 20 to 30 blood transfusion. Most of those people require iron chelating agents like drugs that get the iron out of their tissue after 50 blood transfusion. I mean, give or take, just an estimate numbers, and bodies are different. Sickle cell trait can be seen in many regions. It is kind of concentrated in Eastern Africa and uh, North Africa, southern part of the Arabian Peninsula, maybe India, stuff like that. So the last case that we've got, a 13-year-old male, complains of skin pigmentation, abdominal swelling, and pallor. He has been receiving blood transfusion since the age of 9 months, so he's a transfusion dependent. Definitely has a stunted growth because of his chronic anemia, very low MCV, elevated retic count, and an evidence of iron overload with a ferritin measures 5,000. Widening of the skull. This is related to the extramedullary hematopoiesis. A huge spleen can be manifested as a significant abdominal distension related to the chronic hemolysis and extramedullary hematopoiesis. Chipmunk features like very protruded uh, parts of the face, frontal bossing. So this is a typical finding of thalassemia, which can be manifested as a very mild disease in some patients to a very major and catastrophic disease in other patients. Most of patients who have a thalassemia major disease are transfusion dependent with hemoglobin concentration below 7. Um, and that depends on how many genes are affected and what the globin chain, what kind of globin chain is affected. We have imagine if we have like two affected beta chain, then you will end up having a thalassemia major disease, beta thalassemia major. One indicates minor, intermediate. It's a mixture between both, so moderate form of anemia. And this goes for the beta thalassemia. In alpha thalassemia, where the alpha chains are affected, there's 4 different problems ranging from death in utero to a mild form of anemia because we have 4 different alpha chain. So most commonly reported mutation in the beta globin genes in Jordanian. I mean, nobody will ask you about this, was just for your knowledge. So 8 mutations constituted about 86% of Jordanian thalassemic mutation. So how people present: extramedullary erythropoiesis, iron overload, dilated cardiomyopathy as a secondary to the iron overload and to severe anemia, growth and development retardation, large spleen, massive spleen. How we prevent it, how we treat it. It's the first thing is we just prevent it with the application of the premarital testing, in which people who have anemia, low MCV, can be having further testing for thalassemia with hemoglobin electrophoresis or alpha thalassemia genetic testing can prevent people who's having problems related to thalassemia from getting married together. And as a result, if you don't get those people uh, married, you reduce the risk of having offsprings with thalassemia. So, in the unlikely situation in which a patient is born with thalassemia, depending on the severity of thalassemia, if you're dealing with thalassemia major, then blood transfusion and after certain point iron chelation and maybe splenectomy, and the most definitive treatment sometimes would be the allogenic transplant would be all indicated for those patients. And thank you very much. Do you have any questions? I think we're done for today. أي سؤال شباب؟ صبايا. طيب يعطيكم العافية. شكرا.
يعطيك العافية.